Then we are talking about, we already discussed this one. So the consistency and the values are very, very important. Checking for the values and how you are going to manage it. This is something very, very crazy, and they do like to ask a lot of questions from here. Then they are talking about what are the contraindications, maternal, fetal, and then fetal. Maternal is basically teen, C-section, cesarean delivery, unstable. In those cases, we don't go for the uh, like induction. Induction mainly you can think of wherever you have a chances of thinking that they can rupture. In those cases, we don't go for. Or there is any chances of transmission of infection. Just keep that in mind. So you can see T cells insertion, it can cause rupture. Then uterine rupture, it can cause rupture. Then the invasive cervical carcinoma, in that cases, can be ruptured. Then pelvic structure abnormalities, obviously, it will not able to pass through. Then genital herpes is like an infection. Then the placenta previa, obviously, it can cause rupture. Cord presentation, it can cause compression and then death. Fetal distress, it can cause death. So just to, for your idea, wherever there is a chances of rupture or where there is a chances of spreading infection, in those cases, we don't do induction of labor. Then the method of induction of labor, very, 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 very important. If you don't know anything, induction of labor, at least know the methods. What are those ones? Cervical ripening. So when I was doing the revision, I try to only memorize the, like, what is the cervical ripening. There is prostaglandin gel that we use. Okay, that's how I do the revision. But when I was reading it for the first time, then you have to go through a little bit more detail from that one. Then in that case is the cervical ripening you have to do with the prostaglandins. Ripening of the unfavorable cervix to make it prepared. So you have to go for the intravaginal prostaglandin gels or maybe capsules or whatever it is. So it could be intravaginal capsules, it could be intracervical, intravaginal PEG1, the misoprostol one, and then Foley's catheter. So which one is used along? Misoprostol one, it is long and close cervix. In this one, we use this one, and it's inexpensive and stored at room temperature, so mainly preferred. Then the induction of labor or amniotomy. So yeah. Then the artificial rupture of membrane, in that case, is to stimulate the prostaglandin synthesis and secretion. May try this as initial measures if cervix is open and soft and the membranes can be felt. If the head is well applied to the cervix, few studies applied for the amniotomy. So now a question can come where they're asking for the cervical ripening and asking you which one is preferred over the other one. So like they give you an option of prostaglandin, they give you an option of amniotomy and going for oxytocin and etc. So the most preferable one is prostaglandin because it does not cause any infection or nothing like that. In amniotomy, it's basically used, but there is high chances of spreading of infection. That's why we prefer prostaglandin over amniotomy. But if you are using it together along with oxytocin, it is basically preferred. Now, as you can see, amniotomy plus IV oxytocin, more women delivered vaginally at 24 hours than amniotomy alone. So in that cases, if they are talking about amniotomy and oxytocin, and they give you an option, how do you do the induction of labor in a normal female, whatever she is normal, she has no problem, nothing at all. So we are not talking about any exceptional case. So they gave you an option of prostaglandin, they gave you an option of amniotomy, they gave you an option of amniotomy plus oxytocin, or they gave you an option of non-watchful waiting. In that cases, first of all, we have to see that watchful waiting. Okay, if watchful waiting is excluded, like we have been waiting for 10 hours and it's nothing going on, or the baby is more distressed, and in that cases we can do the delivery. So the next option will be prostaglandin. Still, we are not going for amniotomy or not going for oxytocin. When we are out of the option of prostaglandin or there is a contraindication of prostaglandin, then only we can go for amniotomy. Okay, then only we can go for amniotomy plus oxytocin, and then the last option will be amniotomy. Okay, just why? Because amniotomy can cause a lot of infection, although it's not written here, but it's not preferred very easily. Okay, then oxytocin in 10 units in normal saline reduce the risk of unsuccessful vaginal deliveries. Dosing regime for the oxytocin is not known. Current recommendation use the amount of the oxytocin. Then it causes the tetanic contractions, then the muscle fatigue, muscle uterine atony, and the vasopressin-like action causing the antidiuresis. So for your idea, which one preferred, which one over the other one? So augmentation is basically done with the amniotomy, and the oxytocin may be used to promote the stronger and more contraction when the spontaneous contractions are inadequate, and then cervical dilation or the descent of the fetus fails to occur. So in that cases, do look into very closely that in the options or in the scenario, did they talk about amniotomy? Did they talk about that fluid is all gush of fluid is already out? It means the amniotomy has been done. Then what is the next option? Sometimes we are not even sure that what's going on. So if they have not written down anything about amniotomy, but they says there is a gush amount of fluid already came out, it means the amniotic fluid is already out. So amniotomy has been already done or happened. So in that cases, the next option will be oxytocin, not prostaglandin or anything else. But if they did not talk about that one, then we are still in the very start. So think of which stage you are and what is the next step you have to do. Provided there are no contraindication, oxytocin is used to provide. So in that cases, we will go for that one. Then abnormalities and complications of the labor and deliveries. So abnormal progression of the labor, like with this dystocia, we already know the passage, passenger, passage, and psyche. So we have to look for whichever the level is problem, and then we go along with that one. What is the management? Confirm the diagnosis of the labor. Search for the factor of CPD, then concern of for dystocia and management of CPD. So for the labor, you have to make sure that the patient is already in the labor or it's a false contraction. If it's a false contraction, then we have to stop the contraction. If it's the true contraction, that we have to induction of labor or augment it. So please do make your diagnosis very strong that you are not helping a false labor, you are helping a true labor. Risk of dystocia, the maternal stress, infection, PPH, neonatal resuscitation, compromise, rupture, and hypotension. Then the shoulder dystocia, uh, like in that case, is a macrosomia, baby, diabetes, mellitus, multiparity is basically the most one, and then the most common is happening in the prolonged second stage. So mid-stage delivery in that one's the one most important sign that you will see or they will give you in the scenario is the turtle sign, and you have to see how does it look like. Usually the baby head is outside. The complication, what are the most common complication? The hypoxic ischemic encephalopathy, brachial plexus injury. We already saw how it works. Then the fracture, then the death, prenatal perennial injury, PPH, and then rupture. The goal is to displace the anterior shoulder inside and then switch and move it outside. The cleodotomy is done, Zenevely maneuvers and symphysiotomy, so you don't have to go into very that one. Then you can see how do you go for the shoulder dystocia. What is the first thing? Like how do you make that? Mainly the important thing is how do you take out the anterior shoulder from the one. So anterior shoulder disimpaction and then going for release posterior shoulder and then doing the corkscrew and bringing it out. Now coming for the cord prolapse. There is many things related to cord, umbilical cord, like very many questions. So keep it in your head how you are going to preserve the umbilical cord. So the presentation is it's visible and fetal heart rate because fetal heart rate is very much linked with the umbilical cord. And you need to know what it causes. The variable deceleration is called by the umbilical cord prolapse. One of the most common question, okay? The umbilical cord accidents causes the knuckle cord, type A, type B, body loop, single artery, true knot, torsion, filamentous, and then all of this one. How do you do emergency cesarean delivery? Because baby can die, oxygen, elevate the pressure, keep cord warm. One of the most important thing. So when you are going for the vaginal delivery, a question can come like the patient is having the umbilical cord prolapse. Patient is wanted to go for the vaginal delivery. She does not want to go or she rejected for the cesarean delivery. In that cases, what are you going to do? Keep the cord warm and moist by placing it into the vagina and applying the warm normal saline soak. So you have to do, although we are going for cesarean delivery, she does not want to do it or whatever it is. In that cases, the first thing is keeping the cord moist. And if not, at least writing it down or keeping it in your head that the first thing is let it not dry or let it not get cold. So roll the mother in the four positions. And if the fetal demise or too premature, then you have to allow the delivery. Then comes the uterine rupture. In the uterine rupture, the most common presentation is fetal bradycardia. Because uterus is ruptured, more than mother, the baby will be having the problem. Although mother will be going into hemorrhage and all that, but the baby will get into fetal bradycardia. Then there is shock, bleeding, hemorrhage, and all of that. Risk factors, what are the risk factors? The uterine scarring, like a previous surgery happened, uterine stimulation, trauma, multiparity, anomalies, malpresentation, and accreta. Rule out the abruption, maternal stabilization, like it's an emergency. than immediate delivery for the fetal survival. Now we are talking about amniotic fluid embolism. It's just very hard to make a diagnosis of amniotic fluid embolism. I don't know why, because it never comes to my mind when I'm making a diagnosis. I don't know if you guys can keep it in your head. Like wherever the maternal circulation is the problem, or they're talking about anything with the, like, they were giving a delivery and now she's having a shortness of breath. I kept on thinking about pulmonary embolism, but I never think of amniotic fluid embolism. I don't know why. But if you have an idea, or keep it in your head. So usually what happens is amniotic fluid debris in the maternal circulation causes this immunological response. So it can present with the rapid labor, like a mother is giving a delivery and now she's having shortness of breath and all along with all kind of symptoms like a respiratory distress or collapse. So in that case, is like during delivery, they're talking about don't think of pulmonary embolism, think of amniotic fluid embolism because the risk factor is rapid labor, multiparity, uterine rupture, manipulation, induction medication, and then procedures. So differential diagnosis is pulmonary embolism. But since they're talking about delivery, they're taking you towards especially the amniotic fluid. So the main important thing they're looking for, if they're giving you an idea of this one, so it's basically amniotic fluid embolism. Then the septic shock, eclampsia, HELP syndrome, structure, and then the coagulopathy. So usually it do come along with some sort of infection. Okay. But in when they are mentioning in the exam or in the scenario, they don't mention about any kind of infection. Like they do mention about tachycardia, they do mention about the respiratory distress, they do mention about the delivery, but I don't know, my mind never went towards the amniotic fluid. So you guys should keep it in your head. Respiratory distress, cardiovascular prolapse, the hypotension is there, then the coagulopathy, ARDS, and left ventricular dysfunction. So in that case, it's going for ICU and then ventilatory support and all that. Mainly, management is keeping the stabilization, but making the diagnosis itself is very challenging. Then the chorioamnitis. Since the chorioamnitis is one of the most common presentation after amniotomy, okay, so that's why amniotomy is not very much preferred. And the most causating agent that causes it's basically GBS, although there is bacterioids, E. coli, and all of them. Low parity like prolonged rupture of membrane, long labor, vaginal exams doing again and again, then bacterial vaginosis and other infection. Where there is a mother more than 38, tachycardia, that's why they give the prophylactic antibiotics now if you start making sense because of to prevent this condition. Uterine tenderness, foul and purulent cervical discharge. We go for CBC and amniotic fluid, we check for the glucose and any culture. We go for IV antibiotics and even some cases we go for the prophylactic antibiotics even if it's not confirmed. Antipyretics and then the labor progression should be watched, not an indication for the cesarean delivery. So you don't go for cesarean delivery. Just for your convenience, I would suggest when you are going for obstetrics, write down what are the indications of cesarean delivery and what are the indications of vaginal delivery. That will help you a lot in management. Okay. So make your own table. You won't be able to find a table in Pronto Notes like that. So you have to make your own table. Complication is bacteremia for the middle mother and fetus, both of them, causing sepsis, meningitis, sepsis, and death. Then you already know what is the meconium. So a question can be asked like a mother or the baby's passed and now he's passing a black or dark green stool. So in that case, what is it? So it could be normal. So it's basically they're talking about the meconium. Then particulate meconium is associated with the lowest Apgar score, increased risk of meconium particulate, and then darker green are the one it is. So in that case, is looking for the call respiratory therapy if somebody has ingested that one. Here, when you're talking about operative, in this one, just that's what I was talking about when you have to do the indications for the forceps and vacuum. Okay. The most important is the indications. It will help you a lot with the management. Then the contraindications like the cervix is not fully dilated, so you're not able to do or head is not engaged in that cases. What is the benefits of the vacuum over the forceps and what could be the complications? Then, when we are talking about the perineal laceration, the first degree, second degree, third degree, fourth degree, it can be given in a scenario and ask for direct management. They won't ask for what is the first degree, what is the second degree. They will ask you for the management because the management will help us give an idea that you guys know which degree it is. For the third and fourth degree, so usually for the first, second, we just keep a watchful wait. For the third and fourth, a single prophylactic IV antibiotics is given. Laxatives should be prescribed, and then postpartum pelvic physiotherapy should be given, and then endo-anal ultrasound to check for the anal sphincters. Then episiotomy. So which one is better? The one that is already been done or the one that you give? So basically the one that we give, the mediolateral one, because it has more healing benefits as compared to the medial line. Complications, infection, hematoma, and then musculature. So when you are doing a cesarean delivery, I would suggest only the indications is more than enough for you. And if better, you can read the complications as well. Okay, now it comes to the postpartum. Now the baby is out, mother is out. Okay, so postpartum period complication, the postpartum hemorrhage more than 1000 ml after the cesarean delivery or more than 500 ml in the vaginal delivery. So you can see in the cesarean it's different, in the vaginal it's different. Primary within 24 hours. So what are we looking for? Tone, tissue, trauma, thrombin. So you have to see each and every one has different one. So when we are talking about tone, the uterine atone is one of the most common cause of PPH. It can be asked straightforwardly what could be the most common cause of PPH. The one, it is basically uterine atony. Avoid, how do you avoid? One of the most important, because what you can do to avoid it in that case is the most important is oxytocin administration, uterine massage, and umbilical cord traction. Just give me a second.